My name is Dr. Benson, and I'm a professor of medicine and a GI medical oncologist at the Feinberg School of Medicine of Northwestern University and the Robert H. Lurie Comprehensive Cancer Center. I wanted to first make a comment that these available markers, and there are a number of potential markers that could be tested, are not to be utilized for diagnostic purposes. These markers are considered for individuals who have been diagnosed with a neuroendocrine tumor. I think once you have a diagnosis, one of the first steps is to determine, is this a functional or non-functional tumor? For non-functional tumors, and I think some of the most common markers that people have utilized include chromogranin A, and particularly for patients with mid-gut neuroendocrine tumors, 5-HIAA, which I currently measure from a plasma sample, but historically has been measured from a 24-hour urine collection. There are for non-functional tumors, for example, with patients with pancreatic neuroendocrine tumors, there are a number of markers that can be determined, such as pancreatic polypeptide, glucagon, gastrin, and so forth. But I would say for the non-functional tumors, I think the utilization of these markers is quite limited because the bulk of treatment decisions are based on imaging in particular. And perhaps if people have symptoms that are not related to a functional status, but maybe related to the location of their particular disease. There are patients who may have very high levels, for example, of chromogranin A, that you might utilize during treatment as just one indication of benefit from response. But I think in general, the use of chromogranin is controversial, and in my practice is generally not very helpful. For patients with functional tumors, however, that is somewhat a different story because the markers may be helpful in helping determine if there is a response. Although also with the non-functional tumors, the guidelines in terms of how well a patient might be doing in terms of a therapeutic intervention are really most dependent on imaging as well as symptoms. One great example of a functional tumor is the carcinoid syndrome. And many individuals with carcinoid syndrome will have elevated levels of 5-HIAA that can be followed. And of course, the syndrome is characterized principally with flushing and diarrhea, and we look for improvement in symptoms for patients undergoing therapeutic intervention, such as with somatostatin analogs. For functional pancreatic tumors, there are of course, people who have insulinomas, and there are markers to follow, such as insulin, proinsulin, and C-peptide. Patients with glucagonoma or gastrinomas have specific markers that we can follow. But in general, I advise that we determine if a patient has a functional or non-functional tumor, and then determine in the end how much will marker determination inform you in terms of how well a patient is doing during a treatment intervention.